All right. Hello, everyone. Thank you so much for joining us. We may have some more folks join over the next few minutes, but we're going to go ahead and get started so we can have plenty of time for some good conversation today. Today, we're going to be talking more about the community-centered health home model, specifically looking at community-centered approaches to racial and social justice. My name is Lauren Bernard-Davis. I use she, her pronouns. I'm the Senior Research Manager at the National Healthcare for the Homeless Council. And we are very excited to have Katie and Sandra back with us from the Prevention Institute to take a closer look at this model. Before we jump in, I just had a couple of quick housekeeping notes to share. First of all, today's webinar is funded through a cooperative agreement with the Health Resources and Services Administration, but the views shared do not necessarily reflect HRSA's positions. If you're unfamiliar with the council, we are a membership organization focusing on training, research, and advocacy in the movement to end homelessness, and our foundation is in human rights and social justice. Today's webinar is a meeting style Zoom room. So when you came in, you saw everyone in gallery mode. So you are able to unmute yourself and join in the discussion later. You should be muted at the moment. And we ask that you keep yourself muted when you're not speaking, just to limit some background noise. With that, I'm going to go ahead and hand it over to Sandra to get us started.
Thank you so much, Lauren, and hi everyone. It's so nice to see some faces and names there. Some I know we had the pleasure of getting to engage with and connect with not too long ago, a few weeks ago. I'm Sandra Vieira. I'm an Associate Program Director at Prevention Institute. We're a national nonprofit with staff and offices in Oakland, Los Angeles, Houston, DC, and beyond. And our work, as our name might imply, is focused on prevention and primary prevention at that, and addressing the root causes of inequity and of poor health and safety, well-being outcomes. A lot of our work is about connecting, engaging, partnering with organizations, health systems, community health centers on the ground, and getting to facilitate, support their efforts, and also take those learnings and share them with others to spread the knowledge, insight, wisdom, wealth elsewhere. So I think that is one of the reasons that we were so graciously invited to participate in this webinar series. And we're so thankful to Lauren and to you all for inviting us back. We're hopeful that the models, examples, questions, information we share might be valuable to you all in the work that you're leading in your communities. So I'm going to just hand it over for a second for Katie to introduce herself, and then we'll get going.
Hi, thanks, Sandra. Good afternoon, everyone. My name's Katie. I'm Sandra's colleague based out of Prevention Institute's Oakland office. It's really nice to be with you all today. Not a lot to add to what Sandra shared, except for that we're really excited to talk a little bit more with you all about the work we've done over the years with healthcare organizations and other partners, and to hear a little bit about the work you all are doing in this space as well. So very excited to be here all with you today.
Thank you, Katie. We are going to jump right in. We know some folks had an opportunity to be part of last month's session, and some folks are just jumping in, and that's totally okay. Folks are welcome to just jump in and kind of follow along. I'll share a little bit of some of the elements and kind of concepts that we touched on last session, and then from there, Katie will walk us through sort of the second part of the community-centered health homes model that we began to kind of do a deep dive in last session. So our focus last time was to think about the big call to action around supporting health and safety, well-being outcomes that we know are so important across the nation in our communities, and thinking about, well, what are the models, the frameworks, the ways in which we can approach such a big ask and need. So we began to describe and to share with you all the community-centered health home model that we have helped to capture and describe and share out. And it's based off of the work of community health centers across the nation. I think one major takeaway that we are inviting you to kind of continue to have top of mind as we follow through our conversation today is that a community-centered health home not only acknowledges that factors outside the clinic walls affect patient health outcomes, it actively participates in improving them. Over the last decade plus, we have done all such a great job of really making the connections between illness, injury, behaviors, exposures, and then thinking about what surrounds us and how that shapes health. And that has helped to turn our corners, turn tides, turn all the things to get us primed to be involved and then to engage in action. And I think one part that's really helpful in keeping in mind with this CCHH model is that there's the recognition piece, but also the how does a community-centered health home also actively participate, engage, and support efforts outside of the clinic walls. One of our, I think, colleagues, partners, I think inspirations in this work, summed it up in a really great way. The CCHH model represents more than a one-time effort to improve community health. Instead, it's a cultural shift of how clinics think about their role in improving their surrounding communities. And as we know, cultural shift, norms take time and take process to change. And so I think the CCH model offers some avenues and pathways to go from an effort to a culture and to a set of norms and a way of operating moving forward. We shared a little bit about the Asian Health Services example, I think just like a beacon in the CCHH world that really informed our thinking about what are the elements of a successful, effective community-centered health home. And we described sort of their early work going from an incident, a set of events, and moving that into coordinated action, partnership, engagement on the built environment policy level, in the community engagement, business community engagement, and then moving that into also exploring economic development in their local area. I think in the years since some of these efforts that we highlighted have taken place, Asian Health Services has done work at the state level. They've been involved in things like healthy nail salon efforts to protect both clients in nail salons, but also workers, and support the health and well-being of workers in an industry that really, required some additional protection. So they've really been able to build and get to that cultural shift in the work that they're doing. And I think akin to the other kind of framework and examples we were speaking to last time, which is moving upstream, not abandoning the work that they do and that community health centers are so much needed to do in the downstream areas of providing quality, affordable, accessible clinical care that supports people sort of where they are in their health status, but moving upstream and thinking about the individual social needs of their patients, clients, partners, and even moving further up to think about the community conditions and the structural drivers that affect people and communities, populations' entire ability to be healthy and safe overall. So we offer this as sort of a complementary framework to consider, well, where might you be? And where might you be interested in moving along? And one of the things that has continued to stand out to me from last month's conversation was some folks started saying like, oh, this could make for some good conversation, a good set of dialogue with our team, with our staff, with our partners, to see maybe if we are not midstream or upstream yet, do we want to be? How might we get there? What would it take to move upstream? And I think those are exactly the right questions to consider and to be thinking about in short, mid, and long-term areas. One thing we wanted to kind of add to the conversation that we prompted last month was thinking about something that you all think very closely about and are helping to lead, I think, across the nation, what can be done, which is in the area of housing and supporting people who are experiencing homelessness or housing insecurity. when Katie and I began working on an initiative several years ago that brought together a health system, local hospitals, to move into policy change and to think about health equity and racial justice, we really created the space to say whatever sort of community determinant of health or social determinant of health that you think is most important in your community should be what you do. We didn't want to kind of prescribe that or pre-identify that. And these are hospitals across California with different political climates and economic climates all across the state. Across the state, I think almost every single one of those communities, those partnerships in those 7 areas identified housing instability, lack of affordable housing, a lack of healthy and safe housing as a kind of generational issue within their communities. And I don't think that's specific to California. I think that is a national issue that we are all seeing and facing, and that has come really to a standstill in terms of like the needs that we need to address and the movement that we need to make to support housing in the long term. So we kind of develop this brief reflection of how housing efforts might line up along those streams of prevention. When we think about downstream prevention in relation to housing, the importance of providing emergency housing vouchers, funding shelters for people experiencing homelessness, supporting the immediate mental health and physical health well-being of people so that they can find a place to be safe. Just as a starting point, you can't go further without supporting people in their deepest need. And as that layer is sort of addressed, thinking about midstream, providing transitional housing services, assisting with short-term housing placement, building housing for patients with complex health issues, housing issues and social needs. We've seen a lot of health systems start to engage in partnering with housing developers and coming together and sort of saying, well, how do we build a longer term support for housing needs? And I think we can continue to move upstream and think about addressing the discriminatory policies and practices within housing administration at a federal level, state, local level, just knowing that there's so much to address there, whether it's people returning from incarceration or having, not had a captured, employment history that oftentimes is a requirement for housing, not being able to bring families together within housing, like all of those really limiting people's ability to secure housing. Advocating for livable wages and local economic development opportunities, because we can create housing, but if we can't afford them, then we're not really addressing the issue. And all of these are very complementary and need to happen concurrently in order to get to the bigger issue, influencing local, regional, and state zoning and housing policy, and identifying funding streams to support housing development in local communities. I think there's a lot more that could happen here, including how do we support the holistic approach to individuals and communities and their needs to access housing, which has to do also, with mental health and with physical health and well-being as well. But we offer this as a sort of starting point and as a way to start to envision what upstream prevention in the area of housing might look like and what efforts might be underway in your own communities. I think what's inevitable to acknowledge and recognize is that in our efforts to support health, to get to health equity, we have to recognize the interdependence of health equity and racial justice, that we won't be able to get to the outcomes that we seek in health if we also don't address the structural issues that we have in our society that affect Black, Brown, Indigenous, and people of color very specifically, past, present, and if we're not thoughtful and very intentional about efforts in the future. So the combination of really looking at things through a health equity and racial justice lens is the need, and it is the present and the future that we need to bring together. We'll drop this in the text chat. I think we mentioned it before. We have some thoughts and some offerings around bridging health equity and racial justice together, and I think tries to make the case for why it's important in order to get to our public health and health equity outcomes to also address racial justice and other forms of inequity and justice as well. I think what sums it up for me always very clearly is that working to narrow gaps in health outcomes without intentionally addressing racism and the multiple forms of discrimination associated with it thwart successful outcomes on both fronts. So we need to kind of keep that in mind and work together to make this movement happen. So what we try to offer in that, because that is a big ask, it's a big kind of goal that we have forward, are ways to do that. And so a few ways that we have elevated and helped to communicate and disseminate are frameworks that think about equity, sort of the goals of equity, and then sort of the ways in which we can approach that. So we're sort of sharing a bit of that in our conversation today, but we're happy to kind of like unpack it a bit more in our question and dialogue section. One of the frameworks that we think about and share in the bridging health equity and racial justice paper is the equity by sort of objective, that in order to get to this kind of big idea of equity, we can think about it in sort of three different ways for three different purposes. We talk about it as procedural equity, distributional equity, and structural equity. And while I'll sort of mention it in a linear kind of siloed way, we really think about the connection between these objectives of equity, because one relates to the other and one is only possible by the other sort of existing and happening at the same time. So procedural equity, this is about ensuring transparent, fair, and inclusive processes with additional opportunities to engage and have voices amplified for those who are disproportionately impacted by the issues that we're seeing. So when you think about this, you might think about things like community engagement and participation. You might think about community or resident leadership, youth voices, a lot of really good and exciting work happening there. And the idea is that the people in the communities most impacted by the existing inequities are the ones not only talking about the problem, but also talking about and leading around the solutions. Now, procedural equity is very complex, and it's hard to kind of get to our goal there because there's so many factors in place that limit those folks that are disproportionately impacted from engaging in the processes that exist, whether it's things like knowing that these conversations are happening with our municipal governments or at a state level, having the information, having the accessibility to get to that. But even once that has happened, how one is able to engage in these conversations, the technical nature oftentimes of some of our governmental opportunities to secure funding or to voice opinions is very limiting, and it is very exclusive at times. So instead of always kind of thinking about bringing communities to a process, it's how our different agencies, partners, public and private, can come to the spaces and the places where our communities are. And I think in particular, and I'd love in our kind of Q&A and dialogue piece to just, learn about the specific limitations and challenges of the populations and communities you serve and work alongside with in being part of transparent, fair, and inclusive processes. So I'm going to put a tiny kind of thought pin in your minds to come back to so we can talk about how to sort of address some of those challenges. Distributional equity the fair distribution of resources, benefits, and burdens, prioritizes resources for communities experiencing the greatest inequities. I think when you think about sort of the different elements of equity, distributional might come to mind, because we can think about sometimes the funds that come in from the Centers for Disease Control and Prevention, or at the state level, or even locally, that says we want to support housing or mental health services or chronic disease prevention in areas that are red for X number of reasons and X number of issues. And so we might be more familiar with that type of equity. I think the piece that becomes difficult here is that if resources fall into the same places or into the same processes that have contributed to the issues we face now, we won't see the different outcomes in that. So for example, in this image here, we could imagine funding coming in for park poor communities, and we might have the information and the data that tells us where those park poor areas are. But oftentimes, because funding comes through, let's say, county level, and county representatives represent a number of communities, as in the case of the Bay Area or Los Angeles, for example, even those funds that might come into a county that is experiencing park poor areas isn't going to be able to directly funnel those resources to the specific cities or even neighborhoods that are needed at that level. And we've seen that happen in a lot of our park efforts, where funds are coming in, and instead of sort of saying we need to start with the areas that are most in need, that have been historically disadvantaged for so long, it's sort of like we'll divide it among all of the different communities, including areas that have historically received funding or are not as in need as others. And so we really have to be explicit and intentional about the distributional equity part. The third one I'll offer here, the objective is structural equity, and addressing the underlying structural factors and policies that gave rise to inequities in the first place, and makes a commitment to correct past harms and prevent future unintended consequences. So we talked a little bit last time about all the different kind of historical policies or processes that have contributed to inequities in parks, in housing, in different kind of social determinants or community determinants of health. And the structural equity piece sort of says we must also do more to address past, present, and think about the future unintended consequences of all of our actions. So what would counter or disrupt some of those gears that we looked at, whether it was the way our highway system was set up, redlining, et cetera. We need to we have to consider those and also think about the efforts that will counter those pieces. So that might be really looking at some of the things we mentioned in the streams of prevention. What does affordable housing policy look like? How do we think about density in different ways? How do we kind of reimagine new policy levers that allow people and communities who have been excluded from this to be part of the process moving forward? So all of those three happening at the same time. And those are our very big elements. Those are big asks. And I think one piece as we move into our next session to consider is that community health centers, CCHH, are part of the solution. We know that this really requires partnership coordination with different sectors, different partners over time. And we know we're going to be doing this work for the next decade, 2 decades beyond that. So that's the context. But I think it's important. Well, what is the role that healthcare and health systems and groups supporting health inequities can play in advocating equity? So I'm just going to toss that hard question over to you, Katie.
Thanks, Sandra. And for folks on the webinar who are listening today, if you have some things that are coming to mind for you based on what we've shared so far, related to the 3 equity objectives we shared. Please feel free to put those in the chat now or sort of throughout the process. The other thing I think we would love to hear in the chat, and I will put this prompt in there myself, is who we have in the room with us today before I start talking a little bit more about the model in particular. So I am going to prompt you to share your name, your location, your organization, and your title or role within that location. And if you want to add to that something that you've been thinking about in terms of a role healthcare can play in advancing equity, I think that would be great. A lot about what we talked about in our previous webinar that we did last month and that Sandra shared about today is really sort of the intersection between health equity, racial justice, and how community health centers can act as catalysts and or partners in advancing some really important change work in their communities. We use Asian Health Services as an example. They're a really strong group based here in Oakland, California. We've been working with them for quite a long time, and you can read more about their most recent work in the 2nd edition CCHH paper I shared a little bit earlier in the chat with you. Our last webinar also focused quite a bit on the work that health centers do in the community, sort of like working with partners or working with other organizations, looking at policy advocacy. And we're going to talk a little bit about that today as well. But we're also going to talk about what happens internally in an organization, be it a health center, any other kind of organization, really, to not only drive this work, but to ultimately sustain it and make it part of the culture of who the organization is. Next slide, please. Thanks to everybody who's putting some stuff into the chat. I appreciate that too. All right, so this next slide is a graphic of the CCHH model that we developed. A previous version of this model, if you happen to have seen it somewhere a number of years ago, we used to have like 3 blocks, which were inquiry, analysis, and action, and they were linear. And what we learned, we kind of knew this from the beginning, but the more we worked with health centers and organizations trying to implement this, the more it became clear that this was not a linear process. This was really a circular process, and folks could be entering anywhere. So inquiry, analysis, and action are the functional capacities that are really about what a health center is doing in their external work. So inquiry is figuring out what's going on in a community that might be causing poor health, illness, and injury. Analysis is working with partners to analyze that information and do some priority setting. And action is really about making changes within the community to address those issues. We're going to talk a little bit about inquiry and analysis and action today in the context of the greater story of the health center I'm about to share about, but we're really going to actually focus on the internal foundational capacities of leadership, partnership, staffing, knowledge, and skills to really kind of give a sense of what it looks like within a health center to do this type of work. And part of the reason I like to pair this conversation with the 3 equity objectives conversation that Sandra shared just prior to this is because those 3 equity objectives are also another way about thinking about what a health center can do and advocate for internally and externally that kind of bridges both of those sectors, the internal and external work. Next slide, please. So in the first webinar, we shared an overview of some of the locations where formal implementation of CCHH demonstration projects have taken place. Today, we're going to zoom in on one of the sites from the Gulf Coast CCHH demonstration project. The Gulf Coast states who are involved in that demonstration project, which was led by the Louisiana Public Health Institute, were Louisiana, Mississippi, Alabama, and Florida. And today we're going to zoom in to talk a little bit about Florida. Next slide, please. So today I'm going to talk about Community Health Northwest Florida, which is a community health center based in Pensacola, Florida. They were one of the original health centers engaging formally in CCHH through the demonstration project led by LPHI, which is actually how we, first informally connected with Lauren from your team. And when she, I think, was interning at LPHI, Lauren, if I'm remembering that correctly. So it's nice that we've been connected through this work all these years. LPHI's CCHH project was supported by the Gulf Region Health Outreach Program, which was developed jointly by BP and the Plaintiff Steering Committee as part of the Deepwater Horizon Medical Benefits Class Action Settlement. I have to read that, otherwise I will forget the words, but essentially it was as a result of the BP oil spill that happened in the Gulf of Mexico that some folks might remember. back in 2010, and this was part of the class action lawsuit, that some funding went to different organizations to support health centers, clinics, and other nonprofits in the Gulf Coast region in support of projects to advance health and recovery. The confluence of events started Community Health Northwest Florida on their CCHH journey. At the time that LPHI's funding opportunity came around, they were facing a financial crisis and undergoing a leadership transition. When CEO Chandra Smiley came on board, she saw CCHH as an opportunity for the health center to reconnect with its mission to serve its patient population and the broader community. Next slide, please. A little bit of background about the health center is based in Pensacola, Florida. It was originally formed in 1993 when the countywide hospital that served uninsured residents closed. It's expanded over the years from a primary care only service providing organization to become an FQHC in 2007, and now has 13 sites. They rebranded as Community Health Northwest Florida in 2017, actually during the CCHH demonstration process, which was sort of part of how they repackaged their work within the community. Their CCHH work focused around C.A. Weiss Elementary School and Oakwood Terrace, which is a public housing complex where a significant portion of the elementary school students lived. The health center was approached by the Children's Home Society and the school district to open a clinic at the elementary school. They used this opportunity to begin reaching out to families to find out more about the community conditions that were impacting their health. Next slide, please. All right, so this is where we get into the model. And I'm starting with partnerships because I think partnerships are such an important part of both the internal work and the external work, right? So Escambia Community Clinic was the name of the health center when they started this process. And, eventually they did become Community Health Northwest Florida. As I mentioned, they were approached by the Children's Home Society to work on this project. They came together to create a healthy school environment, not just putting the clinic into the school, but taking a community-centered approach to really not just look at the data, the quantitative data, although they certainly did look at that, but to focus on getting community input to find out what was needed and what was really going on that was impacting the health of the people who lived in this community. The school took the lead on sitting down with parents at conferences. The clinic went to back to school bashes and did focus groups at Oakwood Terrace, which is the housing complex, and a local university compiled the data that they gathered throughout this process. Children's Home Society took the lead on coordinating meetings and managing the minutes and the agenda. The partnership also includes parents broadly and also in a more formal community leader subgroup. Maintaining partnership fluidity is facilitated by the co-location of all of these organizations at the physical school site. And to show their commitment to each other and the community, the partners signed a 20-year MOU as they started on this process. Next slide, please. So a lot of times folks ask us, how do you staff CCHH work, especially if you don't have dedicated funding to fill a position, like a CCHH manager type position. So for this partnership, Chandra, the CEO, says her vision is that the CCHH team is everybody, but practically speaking, the team is her. She's the sponsor of the team, and it's also led by her director of special programs, who runs not just the CCHH work, but other special programs that are operating within the health center. I think CCHH at the time of the demonstration project was probably about 50% of her total workload. They also had the support of administrative assistant to do logistics and scheduling. All of the staff, however, at the health center were made aware of CCHH to different degrees. The C-suite talk about CCHH at their weekly meetings. And, a few years into the initiative, every single person on the C-suite could give an elevator speech about why their work is community-centered and what that means in action. At the other end of the spectrum, the front desk staff probably couldn't give an elevator speech about CCHH, but if you ask them what makes them proud to do the work that they do, the programs and activities they would talk about are those that have come about because of the community-centered work they've been doing. They also update staff on CCHH-related activities at the annual State of the Union meeting, and it is included in their staff orientation and training on a regular basis. Next slide, please. Also related to staffing is this idea about the knowledge and skills of folks working in the clinic. And this is, again, all the way from front desk all the way up to CEO. It's really important to have designated staff to participate in all the activities. I mentioned that they incorporated this idea into new hire orientation and that they have ongoing discussion of CCHH efforts in staff meetings. So it's just become such a regular part of their work and culture that it doesn't feel like a different or discrete project or program. Next slide, please. Last but certainly not least, I want to talk a little bit about leadership. In my experience, leadership is the thing that makes it or breaks it with community health centers and really, any coalition or organization. Chandra's deep involvement in CCHH as the CEO is absolutely critical to its success, as it signaled the health center's commitment to the community, to the staff, and also, said that we're here to take action and we're going to let you hold us accountable for that. In addition to the changes made with the community and partners, Chandra and her team also implemented internal changes to make sure the approach was sustained, including, the regular updates at C-suite meetings that we talked about, making sure all staff were talking about this type of work and looking for ways to advance the approach in the strategic plan. Also, towards the end of the official demonstration project, Chandra and her team really started to talk more intentionally about how they were operationalizing equity in pursuit of racial and social justice and what that meant in the context, not only of the CAYS community, but also, the broader Pensacola and Escambia County community as well. Next slide, please. Everybody always wants to know about outcomes. And, one of the great things about CCHH is it's so much about building capacity and just talking with the community, working with the community and building relationships. And if that's what someone can accomplish in 2 years, that's a lot. Community Health Northwest Florida also did have some concrete outcomes, both within the demonstration project timeframe and immediately after. A few things I'll share is that they were able to work with the partners to acquire grant dollars to fund a new playground. On the first slide for this example, you could kind of see a picture of a playground. That was what was built and made accessible for all CAY students and residents of the Oakwood Terrace housing complex. Additionally, the school clinic, the Wellness Cottage, is up and running, and Manna Food Pantry, which is the local food pantry in the community, is helping to address food insecurity at Oakwood Terrace by hosting an on-site pantry for residents and students of the school. They're opening a new clinic location in the broader community, which will allow them to increase the number of patients they see by 2. And they decided where to open that clinic location based on the need that was described and brought to them by engaging with community residents throughout this process. Finally, when it comes to advocacy, Chandra says they got their feet wet by being an advocate for Oakwood Terrace specifically. But as a result of their efforts and coordination, they were able to work with the landlords of Oakwood Terrace also to refurbish all 300 units. Some of them didn't have air conditioning. There were some issues with mold and insulation. If you've ever been to Florida or the Gulf Coast, it's very hot in the summer. So some of these things are important. And this was kind of how they got into like a little bit of low-key advocacy. Their leadership made sense in this context, but they're very mindful of trying to find the right balance between leading, but then other times following or supporting the other advocacy efforts as appropriate. They really see their role as activating resident leaders to ultimately be in charge of these kinds of policy advocacy efforts. Next slide. I have a few more things to share about their work, but I want to pause and ask folks to respond either in the chat or if you'd like to unmute. What are you thinking about in terms of how internal structures and processes advance equity, either based on something that we've shared today or anything that's coming up in your own work? I'm going to give folks a minute to see what they want to share. I mean, a few other things that are coming up for me from some of the work that we've done since this CCHH demonstration project is how organizations are starting to think more about their hiring processes, their promotion processes, how they hire vendors in the community and how they can really use their dollars, their distributional power to advance equity in the community. But also, looking at how they operate with community-based organizations and how they choose who they fund and work with. So those are some examples that have been coming up in some of our recent work. Yeah, data collection and analytics, yes. Data collection is a big one that comes up a lot with our partners. One of the things that we talk about a lot is the importance of pairing quantitative data with qualitative data or experiential data. So that's data that's coming from the community, that's coming from interactions, that's not necessarily a number, but can give us some context and to the numbers that we are seeing in more formal data collection. Top-down agreement is necessary to support overall goals. Must be collaboration, yes, definitely. I will say with some of the health centers who focus on data collaboration, which was a lot of them actually to different degrees, it can take like 2 to 3 years to get a data sharing agreement into place. And that actually probably doesn't surprise anybody on this call, but that was a major focus for a lot of people, was figuring out how best to share and exchange information. That's huge, huge. You can, yeah, and that, yeah, there's relationships to staffing and HR structures as well. Okay, let's go to the next question, which is a similar, kind of a similar perspective. Connect with neighborhood residents, yes, definitely, definitely. What is the relationship between internal organizational change and efforts that you're working on in the community? So this idea that there are things that you can do within your own organization, but also that you're working in partnership or working with residents and other policy advocacy efforts. I'm curious for other folks how you've seen those two things kind of align in your own work. Yeah, that's a great comment, John. If organizations don't explicitly prioritize equity and accountability to equitable and inclusive power sharing, then other drivers, grant compliance, yes, politics, yes, will minimize the amount of time and effort spent on building community capacity. That is an excellent quote. We will definitely be keeping that. Thank you for sharing that thought. A big one. You think about things like grant compliance and politics, you know, that's sort of how you see from the other perspective, structural drivers affecting the work that we're trying to do, right? All right, well, while folks are thinking about this question, I can share a little bit more in closing about the work of Community Health in Northwest Florida. On the next slide, yeah, communities approaches from convener strategy, yes. Established goals and governance. Yep, that's a great comment too. I think one thing that comes up a lot in our work with healthcare organizations is finding the right balance between being the convener and finding someone else to be the convener and joining an effort that's already underway. Health centers and healthcare organizations have a lot of gravitas and authority in communities and sometimes really can be a great convener. You know, at the same time, there's often community coalitions who are doing similar work as well. So I always find it that our health centers that we've worked with are really thoughtful about striking the right balance between leading and supporting. And, you know, it's not always one or the other. Sometimes it's a combination of both. All right. Sandra, can I have the next slide, please? So here are some short-term impacts that were reported by Community Health Northwest Florida. Increased staff satisfaction, pride, and connection to purpose were reported as part of employee satisfaction surveys. Chandra and Sandra suspect that by increasing their staff's connection to purpose, they've actually become better service providers too, which makes them more likely to provide high-quality customer service. Staff are more likely to carefully track patients' medication and screening needs and follow up on those. Additionally, the health center has a more positive standing in the community they serve. So those residents feel more comfortable and drawn to receiving services there, services they might not otherwise have been getting at all. So in addition to increased staff satisfaction, they've also seen an increased number of patient encounters, increased number of screenings to meet targets, increased revenue. And I wouldn't say any of those were goals that they had in mind when they started this work, but they are things that they noticed and were able to directly correlate to the work that they had been doing with their community partners. When they first started this process, they were having trouble meeting payroll without needing credit. By the time the demonstration project ended, they had a cash reserve of $5.2 million, enough to cover up to 100 days of operating costs. Additionally, and perhaps most importantly, parents and neighbors were more involved with the elementary school than ever. Teacher retention improved, and first graders passed the standardized benchmarks test for the first time after this process was launched. Next slide, please. I'm interested to look at the point that's come up in the chat too. Managers have to really commit to authentic community engagement. Yes, that is definitely true. It is a challenging shift in dynamics. Yeah, Sandra, that's true too. Because a lot of times healthcare organizations and physicians are used to kind of being in a leadership space. And so kind of navigating co-leadership or co-decision making can be a little bit of a growth opportunity for sure. For Community Health Northwest Florida, I mentioned that they rebranded, they changed their name. People often like to know, how do they sustain this work? So, in the interest of transparency, the health centers who participate in the demonstration projects get funding, right? I think they were getting like $200,000 a year. It's a pretty significant amount of money. What that helps you do is fund dedicated staff people. But what do you do when the demonstration project ends, right? You don't just have another likely $200,000 grant for this specific purchase. They found, because it created so much growth for their organization, that they were able to sustain the staffing for this work through their marketing and outreach budget. Because they had such incredible growth and standing in the community that it really eventually did pay for itself. I don't know if that always happens, but it did happen in this case. They also started budgeting for some low cost, high impact activities. And one specific example is that they set aside $3,000 for 6 months to support the work that Manna Food Pantry was doing, and that provided food security for about 50 people. So just like little ways that they could help support or match in kind with other local organizations. Next slide, please. This is my closing quote from Chandra. Becoming a CCHH has elevated our status in the eyes of our community and enhanced their trust in us. Our volume has increased because people know who we are and that we are here for the long haul. All right, that is the last of the formal slides, and I would love to see if folks have questions, if there's any discussion that's coming up. But yeah, we're kind of want to open it up to the room now to see if there are things that are top of mind for folks. Thank you so much for letting us share with you today. While you're thinking about questions, I am going to put also into the chat the final report from the LPHI demonstration project, where you can hear or read, more about the work of Community Health Northwest Florida and the other clinics who participated in that project.
They included a little unofficial poll temperature check question in the text chat, but folks can also open up lines if that's easier. As you've heard, the different parts of the model, internal, external, curious if you are considering or are already involved in, or you're leading similar efforts via your community health center. I don't know why that says CDC, community health center, within your communities. Curious about and considering, involved already, or maybe you're our next example to share elsewhere. A little bit of time there to respond. I have a sneaking suspicion that folks like John and Pamela, Bonnie, Linda might be involved already in some of these types of efforts. Brooklyn, that is great. Sounds like you are doing it with your housing transition team at UCH. Pamela says, yes, I'm right. Bonnie says not yet, but sounds like considering and exploring there. I'm curious, given your kind of experience, having helped to launch the model and sort of seen it in the Gulf states and elsewhere, like what was the kind of common challenge or limitation, in addition to funding, that centers kind of flagged early on? And did you see any of those demonstrations address that in a sustainable way?
Sandra, are you asking me that?
Yes, sorry, Katie, that question was for you.
Oh no. Okay, awesome. You know, okay, so I'm thinking back. I mean, I would say one big challenge was the extent to which leadership was really engaged or not. If they were engaged in a, yeah, sure, we'll take the money and I'll sign the papers, but like, I'm not really involved in the day-to-day kind of process, those health centers were somewhat less likely to, you know, get into more advanced work. For the folks where the leaders really were involved from day one, many of them already kind of active advocates within their community, that work took off a little bit more. Kind of the same with community partnership. I think one thing that's interesting about CCHH is that it's really an opportunity to build on partnerships that might already exist that you don't think of as formal partnerships. Like if there's an organization that you're already working on housing vouchers with, or transportation vouchers, or you're working with the food bank, you know, on some more maybe downstream or midstream things, you know, to serve your populations. But those are kind of partnerships where you can say, hey, like, what would it look like if we did something broader together? Where are some ways that our policy goals could align with each other? I think even if those were the kind of relationships that existed before, it was already a foot in the door to start to have some of these broader conversations. Screening, yes.
Great sharing in terms of like what folks are already doing and thinking about sharing and offering to partners. And I think the data piece is really helpful, because so much data is collected, and oftentimes sort of limited in being able to share, process, and then figure out, well, what do we do with that? And also what data is missing or what data has been compromised because of some of the structural, you know, issues that we know and recognize exist. So I think it's coming together and looking at that is helpful to map that out and to identify that.
Lauren, I don't want to put you on the spot, but I'm kind of curious to hear what might be coming up for you as someone who was familiar with the model a number of years ago and then now has been working with this organization for a while. Anything coming up for you?
Yes. While I do that, I'm also going to put the link to the evaluation in the chat. If folks could just take a couple of minutes, it's 3-4 questions if you want to add more feedback. But would really appreciate that. And it's so exciting to see this model unfold. When I was at LPHI, they hadn't started implementing this program yet. So it's I really enjoyed kind of hearing what it looked like after I left and was working with the council. But some of the things that I've been thinking about, I know Kendra mentioned in the chat, and I know that John has done a lot of this work too. But thinking about how we interact with the housing system, and some of that is looking at, are we providing services in things like supportive housing? Are we at the table are we doing housing assessments? Are we having conversations about what our systems should look like? And there's a big movement now as we're in the housing world, seeing that the prioritization tools we're using aren't equitable. And so what do we do with that information? And using this model, having the data, having the buy-in, thinking about equity at different levels, how do we infuse equity from the front end and really make sure that while we might be in those kind of midstream, downstream phases when we're thinking about housing prioritization and how we're connecting folks with different vouchers and units and the supports that we're providing afterwards, what would it look like if we were also working with our local continuum of care to think about housing loss prevention and what does it look like to address the needs within our community, really at that upstream level. And I think there's a lot of opportunity in this to take the partnerships that a lot of our HCHs are using and all of the social determinants work that all the folks on this call are doing in their day-to-day work that might not feel innovative because it is their day-to-day work. And what would it look like to kind of kick it up a notch almost, or just think about what would be one step back from this that we could focus a little bit more deeply on prevention. So anyway, I've said before, and I'll say it again, I'm a big fan of this model, and I think there's a lot of opportunity in the healthcare for the homeless world to really think about the prevention piece and what it could look like to deepen our partnerships within our community. So I just appreciate you both again being here.
Yeah, we're happy to be here. Something I've been hearing coming up a lot lately is this idea of a prevention ecosystem, which I think can be helpful for, organizations or folks who might be feeling stressed of like, oh gosh, this is another thing we have to do, and we already have so many other things to do. It's really this idea that you're not alone in doing this work, that everyone has a role to play and things they can bring to the table to advance, health, safety, and well-being for all. But there are others out there in the ecosystem, and it's about, sort of connecting together to move forward, a brighter future for all of us. So I hope you think of it that way. It's in partnership. This is not an additional thing to do, hopefully, but really a different way of thinking about moving the work forward into the future.
Absolutely. Don't want to cut us off if we have more thoughts coming in. I see John talking about the work he did with the local government and community partnerships. Kendra talking about hiring housing navigators, which is such a cool thing for a healthcare program to really embed kind of that system that is often separate and siloed. So that's really exciting. I'm going to put the link to the evaluation in the chat one more time. And then I'm also going to share a link for the council's conference coming up in, oh gosh, less than a month now. So if you are interested in more trainings, more conversation around what it means to do best practices in healthcare for the homeless, we would love to see you in Baltimore next month. And once again, just really want to thank Katie and Sandra for their work and their time and sharing this space with us today. So just thank you all for being here, and I hope that you have a wonderful rest of the day.
Thank you, Lauren.
Lauren and everyone.